Hello and welcome. My name is Ben Geisler and I'm a researcher at LMU's Institute for Medical Information Processing, Biometry and Epidemiology. And I'm also an internist at Massachusetts General Hospital and Harvard Medical School in Boston. I'm very grateful to Dr. Southwick for letting me present this segment in his Coursera course. As a hospitalist, I'm taking care of inpatients. So we'll be talking about therapeutics for patients who are sick enough to be admitted to the hospital in this segment. These are my disclosures, the most important ones being that each decision has to be tailored to each individual case, and also that the evidence is going to continue to evolve. This will be the outline for the next 15 to 20 minutes. We'll first kick off with the case, and then we'll talk about 5 specific and 4 unspecific therapeutics for COVID-19 patients. I'll also mention different ways on how you can keep track of this rapidly moving field. I briefly explain the concept of equipoise and which patients should be enrolled in clinical trials. In closing, we'll apply the 9 specific and unspecific treatments to the case, and we'll summarize. We will not be talking about non-pharmaceutical interventions. For example, proning will be covered in another lecture. We also won't have time to cover therapeutics that haven't shown any benefit, for example, convalescent plasma, or those that are still under investigation, like cytokine inhibitors. For monoclonal antibodies, the benefit seems to lie in early on in the disease course. They reduce the rate of hospitalizations in mild to moderate cases, and therefore they're often used in outpatients. Inhaled corticosteroids are believed to possibly confer a benefit in terms of protecting from severe disease. This evidence is very early stage and is probably also relevant to outpatients only. For RAS agents, ACE inhibitors and angiotensin II receptor blockers among them, and for non-steroidal anti-inflammatory drugs, there's accumulating evidence that there's no specific harm. We won't cover that either. However, both are nephrotoxic. Risk, benefits, and alternatives have to be weighed against each other in each case. And in particular, in a patient with severe COVID, there's a risk that they can contribute to acute kidney failure. So this is our case. We have a 30-year-old Spanish-speaking male without a past medical history who presents with non-productive cough, dyspnea, and pleuritic chest pain for 5 days. On exam, he's wheezing, his heart rate is in the 110s, and his blood pressure is normal. Labs show that he's SARS-CoV-2 PCR positive. His C-reactive protein, D-dimer, ferritin, and LDH are all elevated, but his procalcitonin is normal. His white blood cell count is only mildly elevated, and he has absolute lymphopenia. His BUN and creatinine are both elevated, but his CPK, ALT, and AST are normal. A chest CT angiography with PE protocol shows multifocal groundless opacities, but no PE and also no airspace disease or pneumonitic infiltrate. On the floor, his peripheral oxygen saturation is 89% on room air, but improves to 94% on 3 liters. So let's start with the unspecific treatments. A bronchodilator can be used in patients who are wheezing. We use short-acting beta-2 agonists and/or anticholinergics or combination, for example. In the US, that would be albuterol and ipratropium, or the combination DUNAPs. For inpatients, there's no experience with long-acting muscarinic agents or beta agonists, inhaled glucocorticosteroids, or any other treatments for obstructive lung disease. So the indications are solely for patients who use them at home for their asthma or COPD, and those who are wheezing on exam with the thought that they might improve the oxygenation. Nebulizer treatment, however, is aerolizing, so metered dose inhaler is often preferred as the routine treatment. the additional risk of nebulizers has to be weighed against the additional benefit. However, if a patient is newly being started on a immediate dose inhaler, they of course need to be taught the proper inhalation technique. The second unspecific treatment is intravenous fluids versus diuretics. Standing fluids are not recommended. For nutrition, consider tube feeds instead of dextrose. Avoid extremes. Be cautious with intravenous fluids unless a patient is hypotensive. And even then, consider early vasopressors. Be cautious, on the other hand, with diuretics, as COVID-19 patients are prone to develop acute kidney injury from prerenal etiologies. Do assess the volume status as usual, check the JVD, listen for crackles, especially at the bases of the chest, look for edema and additional heart tones, heart sounds, and do consider tracking their inputs and outputs and possibly daily weights to keep track of their volume status. In terms of antibiotics, avoid routine antibiotics. Only start them if you suspect bacterial infection, but have a low threshold unless the patient is critically ill. For patients who have an infiltrate or asbestos disease on imaging, consider treating pneumonia, for example, ceftriaxone with either doxycycline or azithromycin for community-acquired pneumonia. Procalcitonin alone is controversial, but many have an even lower threshold for antibiotics if it's positive. Do stop if the risk of bacterial infection is low unless the patient is critically ill. And if in doubt, of course, you can always get an infectious diseases consult. Statins should confer a theoretical benefit. They are considered to be mild immunosuppressants. Home statins should be continued, and they should be newly started if there is an indication anyways. For example, to prevent primary or secondary major adverse cardiovascular or cerebrovascular events. Of course, as always, for new medications, do check the medication list for potential interactions. There's also anecdotally a risk of statin-induced myopathy in COVID-19 patients, so do not start them if they're not indicated. And before newly starting a statin, check their CPK, ALT, and AST. There's thought to be a worse risk-benefit ratio if the CPK is over 500 or if the ALT is over 3 times the upper limit of normal. For patients who are on azithromycin and a new statin, do check their CPK daily. So next we're going to go on to one of the specific treatments for COVID-19. Steroids have been used early on in the pandemic in China in many patients, but others were reluctant to start them because there were negative signals in SARS-CoV-1 and MERS, and mortality can also be increased in cases of influenza. But then randomized controlled trials have shown a mortality benefit in severe COVID-19, except in patients who did not require supplemental oxygen. The dosing in the trial was 6 milligrams of dexamethasone daily for 10 days or so. If you suspect gut edema or if dexamethasone is back ordered, you can also give IV steroids, or you could give other steroids, even though the evidence is for dexamethasone. The next specific treatment is remdesivir. Remdesivir is thought to have a direct antiviral effect. It probably blocks the RNA synthesis. And a randomized controlled trial has shown that the duration of the illness was shortened with remdesivir. However, the mortality difference did not reach statistical significance. Remdesivir is indicated for adults and children, except those who have severe acute kidney injury who are hospitalized and have less or equal than 94% of peripheral oxygen saturation on room air, or who require mechanical ventilation or ECMO. They are also contraindicated if the ALT is greater than 5 times the upper limit of normal. In many patients, remdesivir is still difficult to access, but if it's available, do start it early if the patient qualifies, and we'll come back to that later. One of the newer treatments is baricitinib. It's a Janus kinase inhibitor. It is also thought to have a direct antiviral effect. It might decrease the viral entry into cells. There is also an emergency use authorization, but only in combination with remdesivir for any patient who has an O2 requirement. A randomized controlled trial has shown a modestly improved time to recovery, but no mortality benefit. There is mortality in an observational study, but the benefit in patients who are on dexamethasone is much clearer. So a potential use for baricitinib is for patients who are on remdesivir, who have an absolute contraindication for steroids. And in the studies, there was a greater benefit for patients who were on high flow or non-invasive ventilation. The next treatment are IL-6 inhibitors. The greatest evidence at this point is for tocilizumab. There are smaller, earlier trials for this one and other IL-6 inhibitors that did not show a benefit. But two larger recent trials have shown a benefit, but they had different inclusion criteria. Recovery showed randomized patients who had an oxygen saturation under 92% on room air and a C-reactive protein over or equal to 75. Remab-cap had patients included who required organ support, and both showed a mortality benefit, around 12% for recovery and 25% for remab-cap. But the primary endpoint in remab-cap was organ support-free days, and the median was 11 less days on tocilizumab. Both studies had significant limitations. They were both open-label trials. Not all patients, though a majority, were on steroids, and recovery is currently only available as a preprint and has not been peer-reviewed yet. The last specific treatment for COVID-19 is VTE prophylaxis. Unless contraindicated, all patients should receive pharmacologic VTE prophylaxis because it has been shown in several smaller studies that it lowers mortality. Mechanical VTE prophylaxis only prevents lower extremity deep vein thrombosis, whereas in COVID-19, patients might develop thrombosis directly in the lungs, microemboli in the lungs. Lower molecular weight heparin might be preferred, and currently there's no clear evidence that therapeutic anticoagulation provides an additional benefit great enough to outweigh the risks. This slide shows the different time points that were early on hypothesized to occur in the course of the disease. Stage 1 is the early infection where the virus enters the cells and causes direct damage. Stage 2 is a phase where both interlap, and then stage 3 is the phase where the host inflammatory response plays the greatest role. Remdesivir and other antiviral treatments are thought to have the greatest effect early on in the infection. Anti-inflammatory drugs such as steroids were hypothesized to have a great effect in the later stages, but new evidence shows that an early treatment with dexamethasone is beneficial as well. These are various ways on how to keep track of this evolving field and the evidence for it. IDSA publishes guidelines for COVID-19, and they have apps in both app stores that you can download. The NIH also publishes COVID-19 treatment guidelines. Mass General's FLAIR service provides an email whenever there's a new report available on a new treatment. And the New York Times has a tracker for COVID-19 treatments that they categorize in these buckets that you see here. And then finally, our own website, coviddrugs.org, has a developing systematic review where we keep track of the evidence. Let me explain the concept of equipoise next. Equipoise is genuine uncertainty among experts whether a treatment will work or not. In most other situations, we would agree that high-quality randomized controlled trials should be conducted. On the other hand, doctors and other prescribers are allowed to use off-label drugs, that is, therapeutics that are approved for other indications. In COVID-19, there is an ethical dilemma. On the one hand, we really want high-quality evidence whether a treatment works or not, is efficacious. But what if all or most cases are happening right now, and future, more certain knowledge would be less useful than treating right now? So back to our case. Our patient qualifies for both dexamethasone and remdesivir. There's probably no need to give baricitinib or an IL-6 inhibitor. And of course, he should get VTE prophylaxis. For his wheezing, we could give him bronchodilators. Given his tachycardia and his BUN and creatinine are up a little bit, we could consider intravenous fluids and not diuretics. There doesn't seem to be any indication for antibiotics and also not for a statin. So in summary, we can give patients who are bronchospastic bronchodilators. In general, we should limit intravenous fluids and consider diuresis unless, as in this case, patients might be prerenal or developing prerenal AKI. Antibiotics should only be given if there's evidence of a bacterial infection. A statin should only be given if there's an indication for them anyways. Ramdesevia and dexamethasone should be considered for everybody with a peripheral oxygen saturation of 92% or less. And baricitinib and tocilizumab and other IL-6 inhibitors do not have a clear role yet. DVT prophylaxis, low molecular weight heparin, should be given to everyone unless there's an absolute contraindication. And then most importantly, the evidence will change. Keep track by the IDSA's apps, the NIH guidelines, the MGH FLAIR service, the New York Times treatment tracker, and our own living systematic review at www.coviddrugs.org. Thank you.